So we've got about 35 minutes together, and this can go one of two ways. I can walk through the content. It's going to take me 25 minutes, maybe half an hour. And then that extra time is going to be filled with some of the worst dad jokes you've ever heard. And I've got hours of them, so don't test me. Or we can make it interactive. If at any point you have a question, please let me know. If we start to talk about a concept when we get to the pharmacy benefit managers or the stop loss piece that get a little more complicated, just let me know and we'll dive into it a little more. So with that, here's how the time's going to flow. We're going to talk a little bit about self-funding versus fully insured models. We'll touch on level funding a bit, which is the funding method that's becoming more popular with groups of 10 lives to maybe 50 who want to dip their toe in the water of self-funded but don't want to jump all the way in. We're going to spend most of our time on the benefit partners for your self-funded plan. The reason for that is self-funding is really no more work than being fully insured if you have the right partners. And you're going to hear me use the word partners a lot because it's 4 or 5 or 6 folks working together that all need to work cohesively. So they've got to be your partners, not just a vendor. And lastly, we're going to talk about the alliance. So for those of you who aren't really familiar with us, we'll do a little bit of a dive into our history, where we came from, how we got here, and why we think that we're the best network partner for self-funded employers in Wisconsin and Northern Illinois. Questions on that so far? Do I need to break out a dad joke already? Okay. So let's get started with how they're different. So one thing I always like to talk to employers about is whether you know it or not, you're running 2 businesses. The business that makes widget or cheese or computers, you're also running a health plan. When you're fully insured, you don't have a lot of control over it. One of the reasons that we're seeing more and more employers look to self-funding to gain that control. So when you're fully insured, you write a premium check every month to a health insurance company, and that's really the end of your fiduciary duty. They pay all the claims, they handle everything behind it. So when your consultant comes in, he says, here's the plans that we have for our fully insured options, here's a couple of carriers, just pick one, and you're done. But the other things that folks see in fully insured that they're starting to kind of shy away from, and the reasons that they're going to self-funding, you have premium taxes. So that's generally 2 or 3% of your total premium is tax. Self-funded, you don't have that. You have really little control over your plan design. Fully insured carriers have to file with the state every year. Here's the plans that we're going to sell. And unless you are a really, really big group, they're not going to make any exceptions. So if you see plans that are offered that have a $2,000 deductible and a $3,000 deductible, and you want $2,500, you're really out of luck. And I'll tell you, if you're big enough that they'll make an exception, you should probably be self-funded anyway. Madison's a bit of a, I've heard it described as 60 square miles surrounded by reality. That's true when it comes to healthcare as well. It's an HMO-dominated market and has been for a long time. We're starting to see that turn a little bit, which is something we think is good for the employers. The other thing you see in a fully insured plan that sometimes makes folks think, self-funded may be where we want to go, is access to your data. And I think that's, for me, it's the biggest one. You can't control what you can't measure, and if you don't have the data, you really don't know what goes on. And again, same is true. If you're a 800 life group and you're fully insured, you can probably get some pretty good information. But for most groups that are fully insured, less than 250, you just don't really have access to that information. The other thing that really kind of throws a wrench into the fully insured is that you're pooled. So most groups are going to be put into a giant pool, think of a vat, with all the other fully insured groups that a carrier has. So even if you have a good year, your renewal could come out and it says you're getting a 16% increase. Well, why? Well, the pool didn't run very well. Well, why am I getting penalized? Because others didn't do what they were supposed to do with their health plan. So when you start to look at self-funded, And I'm a big fan of analogies. So this one, I think, does it best when it comes to looking at the differences between fully insured and self-funded, because you get to put all the puzzle pieces together on your self-funded program. Reasons that folks are going to self-funded: you get complete control of your health plan. So if you want to have a deductible that's $127.16, you can do it. Your partners are going to look at you kind of goofy, but you can do it. The other thing it does is it gives you control over your plan because you have all your data. We'll talk a little bit about the Alliance and the data that we provide later, but knowing where your spend is going and how you can help your employees find value is a big reason that folks go self-funded. You are judged on your own claims. So at the end of the year, if you have a good year, you win, because the claims dollars that you set aside to pay out, you don't have to pay them all out. You can keep in a fund to pay for your claims in the years that are coming up. You're not subject to state mandates because you're outside of ERISA. So if next year the state says, we think there's an outbreak of toenail fungus coming, you have to pay for everybody to have their toes painted. Well, if you're fully insured, you have to do it. If you're self-funded, you can choose to, or you can choose not to. Most self-funded plans put the state mandates in because they make sense. Any questions on the fully insured versus self-funded piece? So now we're going to talk about the pieces of the puzzle. So there's 6 pieces up here. I would tell you that these are the biggest 6 that you have to have. There are other things you can add. Care management vendors, care navigation vendors, but a lot of that depends on who your other partners are, the services they provide, and what the culture is at your employer. So this is where we're going to spend the bulk of our time. And this is marketing did great work with this slide here. So we're going to start with the broker consultant. So you don't have to change your broker if you're going to go from fully insured to self-funded. But I would ask a couple of questions. One, how many self-funded groups do you have as an individual? And 2, how many does your firm have? Because like I said earlier, if all these pieces don't work well together, your best intentions of putting a plan in that helps you control the second or third biggest line item on your balance sheet won't go as well as it needs to. Because if it does go well, you're able to save money for the employer, and it can be 10, 12, 15%, and you can provide a better benefit plan for your employees. And in a time when everybody's looking for help and employees will move from one employer to another based on a health plan, this will help you retain those employees. So a couple of weeks ago, I had an employer call me and say, Mike, I want to be self-funded. Great. I've done my homework. I know what I need to do. Awesome. How can I help? He goes, here's my first question. Do I really need a broker? And as soon as he said that, I'm like, you haven't done all your homework. Think of a good broker consultant as your quarterback, okay? So they know the markets. They know everybody else that was on that screen. Stop loss, third-party administrators, networks, wrap networks, PBMs. They have relationships with all of them. So they're able to leverage their relationships and what they know about your business to bring the right parties to the table. If there was one TPA and one network and one PBM, anybody could do it. Todd, ballpark, how many PBMs are out there right now?
Well, I would say that 3 or 4 make up 80% of the marketplace, and there's another 30 or 40 out there for sure, maybe more.
Yep.
Coalitions.
And they're popping up every day. So that was an excellent segue to my PBM slide. I'll use that in a minute.
We didn't even rehearse that.
So for some context, we right now have about 340 members in the Alliance using our network. 3 of them do not have a broker. If you don't have someone to quarterback your plan for you, guess who has to call the network when they have a question on a provider? Or the PBM when there's a claim that didn't go through right? Or the TPA when you want to figure out how can we get this paid? That takes a lot of time. And if any of you are in human resources, you already know you don't have enough time as it is to do the things that need to be done, let alone go out and try to track down where the issue is. A good broker consultant does all that for you. I think even more important, 2 doors down, they're doing a legislative update session. Trying to keep up with everything that changes in the law is next to impossible if you have to do it yourself. A good broker partner has on staff people that will do that for you, and they push that content out, and they call and make sure, hey, do you know that next year we have to cover X? Well, I didn't know that. And a lot of folks think, well, what's the big deal? Well, when the Department of Labor gets involved, it's not like they call and say, hey, your fine's $10. Your fine is $100 per day per employee. Well, if I've got a 400 life group and I didn't know about this and they call me in July, I didn't have that money set aside. So the next question that this employer said to me is, do I really need a TPA? You absolutely need a TPA. So in the self-funding world, you can think of the TPA as the person who does all the heavy lifting. So they're going to put together your summary plan description. If you've never seen one of these, it's anywhere from 80 to 130, 140 pages, and it outlines every single thing that your plan is going to pay, and sometimes more importantly, what your plan is not going to pay. They do all of the record keeping when it comes to what your employees have done from deductible and coinsurance standpoint. So they take all the network claims, they take all the pharmacy claims, they manage all that. If your employee goes to the doctor, they send the EOB. When the employee has a question, they handle most of it. Most TPAs are also going to do your pre-certification. So there's going to be things, just like on your fully insured plan, if I need an MRI, your fully insured plan says you've got to call us and tell us why you need it and where you're going so we can make sure that it's medically necessary, because there's a new MRI provider out in Middleton that when you get into the MRI machine, they project movies. So you can lay there for 45 minutes and watch whatever you want. We don't want folks just going to have those for no reason. The other thing they're going to do is manage the fiduciary part of your health plan. So they look for things like duplicates. They do claims edits. The biggest example I've seen of a duplicate, claim came in for a gentleman who had his right knee replaced on a Monday. At the same hospital, they got a claim that says on Tuesday, the same person had the right knee replaced again. Well, that's not right. They catch those kind of things. If a provider says we had surgery and we used 4 surgeons and the code says you only need 2, they're going to catch that and push back and say we're not paying for those 2. So they're the ones that help make sure that your plan runs correctly. Questions on TPAs? All right. So if I had designed this slide or this avatar for pharmacy benefit managers, I would have put them on a horse and given them a cowboy hat, because that's the wild, wild west. I was talking to a consultant just before we came in, and he took a group that was with Anthem, and since the beginning of the year, they've saved $700,000 on their pharmacy spend. A wise man once told me that the difference between being an insurance salesman and somebody who sells PBMs, if you sell PBMs, you don't need a license. They have their own jargon. So you'll hear things like average wholesale price. You'll hear things like rebates. What are the other couple of big ones, Todd?
Rebates are a huge part. The pricing is all over the board.
Yep.
Specialty spend is big. New drugs coming to market, biosimilars, all those things come into play. And that's where you need to lean on a good partner there too to help navigate that.
Yep.
Because it's ever changing.
See, again, a segue. So if you know anything about PBMs, you've heard 3 names. You've heard CVS. Anthem uses them. They account for 34% of all of the pharmacy spend in America. They control it. You've heard of, who's the other one? Caremark, or Express Scripts, that controls 24% of the market. And you also heard of Optum, which is owned by UMR and UHC. So the PBMs are owned by the big national healthcare networks. They have no reason to really work with you to help save that money. You can think of a PBM as similar to a healthcare network. They set the pricing for your prescriptions. They bring the network that your folks can use to get those prescriptions. But outside the big three, we're seeing more and more new TPAs come, and I think the difference with them is they do things differently, and more importantly, and you'll hear this word a lot when we get to the alliance portion of this, they're transparent. So folks like National Cooperative RX, who's based here in Madison, do a great job of, here's what you spent, here's the discounts, here's your rebates. We don't keep the rebates, we don't hide the rebates, we don't try to move the rebates around. There's a couple other, Scout RX has been pretty successful. Their claim to fame is they do a lot of offshore, bringing prescriptions from Canada and Ireland. They do a lot with the rebates that insurance PBMs will give. The other one that has popped up in the last year or so is Shark. So there are good ones out there, but if you don't have a good quarterback helping you figure out what is right for us and how can we best be a good fiduciary of our plan, you end up with Express Scripts and you get no rebates. And we could do a breakout session on PBM that could last 3 hours. That's how complicated they are. So your stop loss carrier, think of them as the underwriter for your self-funded plan. So what they're going to look at is the demographics of your group, where they're located, and what the claims history is for your group, and determine this is what we think your employees should pay into you, because now you're the insurance company. You're going to use their premiums to help pay those claims that they incur during the year. The stop loss carrier is really here to protect the employer from catastrophic claims. So if you think of the routine things, a regular birth, a knee replacement, a colonoscopy, your doctor visits, those aren't going to run you very much money. If you have decided to go self-funded, you could pay for those without jeopardizing your health plan and your business as a whole. But when you get into things like premature babies, cancers, car accidents, those claims anymore, they get to be $1 million in a hurry. And because you're self-funded, the employer is paying all those claims. So if you go a whole month and nobody goes to the doctor and nobody gets a prescription, your TPA sends you a note and says, hey, you owe $0. Well, that's great. Well, the next month, you have a preemie baby, 2 car accidents, and everybody gets a prescription. You get a bill for $300,000. That's what you need your stop loss folks for there. Now, some of the, I'll call it jargon, that you hear when it comes to stop loss, they have deductibles, just like your health plan has deductibles. There's an aggregate deductible and there's a specific deductible. The specific deductible is the amount of money that the employer is going to pay on every belly button before the stop loss carrier starts to pay. So if we're all working for the same company, and we'll use the Alliance as an example. So we went level funded a couple of years ago. This year we're going truly self-funded. Our specific deductible is $30,000. So for every person on the Alliance plan, we will pay $30,000. After that, stop loss picks it up. And how you determine that specific deductible is really a factor of 2 things. One, your cash flow. So how much can we afford to pay on each person? And 2, your risk tolerance. So most smaller groups are going to keep that number $30,000, $35,000, $40,000. If you're a level funded employer, it's probably going to be $10,000, $15,000 because the insurance company sets that on level funded. The larger group you get, the larger your group gets, the higher that number goes. Now, why would I want to put in a larger specific deductible if I got to pay that money? Because you will see your premiums for that specific deductible nosedive as you go from $30,000 to $75,000 to 200,000. We have one group that has a specific deductible of 500 grand because they believe that between them, their broker partner, their third-party administrator, they can manage all those claims under 500,000. So what they're really insuring against, preemies, cancers, car accidents, things that just are so far outside of your control that you cannot control the cost of them. The other kind of deductible is an aggregate deductible, sometimes called an aggregate attachment point, because what the stop-loss carrier is going to do is when they look at your demographics, they're going to say, we expect Bob's Automotive to spend $1 million in claims this year. The aggregate attachment point or the aggregate deductible is generally 25% above that. So in this case, it'd be $1,250,000. If your claims get above that line, stop loss pays for everything. Now, you would hope that you never get there, but having the peace of mind to know this is what I don't have to pay anything above that is one of the safety nets that are put in with self-funded programs to make sure they work effectively. There's another deductible called an aggregating specific, but I think that's more self-funding $275. So we'll skip that one. So the other thing you need to know about your stop-loss carrier and your third-party administrator. The stop-loss carrier has a contract, and you as an employer have your summary plan description that you get from your TPA. Those two things have to match identically. You say, well, what's the big deal if they don't? Let's say the stop-loss carrier says, we're not going to pay for anybody over 60 years old. And your SPD, your summary plan description says, we'll pay to people who are 70. Well, if you have 3 60-year-olds that suddenly incur $1 million worth of claims and you submit that for stop loss, guess what they're going to tell you? That's not what our contract says. And again, I keep going back to having a good broker partner who knows how to leverage and has relationships with everybody else in this puzzle makes your job a lot easier. It takes the burden off of your HR staff to really have to do anything but meet with them to review reports and make sure that the way you set this up is the way that you need it to be set up. I can tell you, first year, you may run into some hiccups. The great thing about being self-funded is a plan is 1 year long, and then you can change it. So the other thing that you're going to see from your stop-loss vendor is they're going to set your coverage period. So what a coverage period does is tells everybody involved, we're going to pay claims that were incurred in this time frame, and we're going to pay them for this time frame. So, for an example, a lot of what we see are 12-15 or 12-18 contracts. And what that means is your planned year runs from January 1st to December 31st. So any claim incurred in that time and paid by, if it's 12-15, by the end of March, is covered by stop loss, we'll have no problems. If you do, some people will sell at 12-12. I wouldn't do it, except in very, very rare cases where the employer insists on it. Because if you do a 12-12 and somebody has a knee replacement on December 17th and those claims don't get filed to the end of January, it's outside the stop loss period. They're not going to pay it. And again, what am I going to say? That's why you have a good quarterback broker partner. I should have had them pay me for this. So the next thing we're going to talk about, this is one that's near and dear to my heart and a few folks in the room. We're going to save that one because after this we'll jump into the alliance portion. The other thing you need is a wrap network. So if you have 150 employees in Madison and you have sales folks scattered in Buffalo, New York, and Colorado Springs and Juniper, Florida, you need coverage for them. And unfortunately, there are not a lot of networks like the Alliance out there that have access to contracts and all the providers that you can plug in. Now, your stop loss carrier, if you have a really bad year, generally a stop loss carrier will offer you a renewal. It may not be pretty, But that's when you, again, lean on your broker partner, and in some cases the TPA, to go out to the markets they have with stop loss and find someone that will take that risk. What you find with TPAs is they generally have a very broad network of stop loss vendors. And stop loss vendors they're interesting animals because some of them say, this is who we insure. School districts and fire departments. That's our sweet spot. We know how to manage it. That's what we like to do. So working with a good TPA who knows, okay, you're a school district, you make cheese, we have a stop loss vendor who loves dairy manufacturers. Great. We go use them. So generally you can come back, but any brokers in the room? Okay. So I can't disavow it, it's on tape. So when I was a broker, I would tell all of my self-funded clients, at some point you're going to have a bad year. Just law of averages. So we set up the plan. In good years, we put that money in reserve to pay for the bad years. Self-funding is a long-term solution. So if you think that if this doesn't go well the first year, I'm going to hop out, you're probably better off to look at level funding because it's kind of a dip a toe in the water. We don't have to go pick our stop loss vendors and our PBMs. It's kind of done for us. But as long as you set that expectation and understand, you know what, this is a minimum 3-year, and I would say give me 5 years to make this thing work, the money you can save is astronomical. And in a time when interest rates are rising and I need to find more money because I need 2 new machines and I got to hire 10 more people, if I can show you how to take your health plan and cut 5 or 6 or 8% off of that, what could you do with that money as an employer? All right, so this part I can do with my eyes closed. You would hope after being here 9 years. So for those of you who aren't familiar, the Alliance, as you see on the screen, is a not-for-profit cooperative. We were formed about 32 years ago by 7 employers in Madison who were fed up with the same things that fully insured employers are fed up with today. We get increases without any really explanation why. We're a large employer, but we still get pooled, and we cannot get our data. We want to understand why are we getting these increases. The thing that makes us different, because if somebody says to me, in one word, tell me who you are, we're a network. But that's where the similarities stop. And the reason for that is because we're a not-for-profit cooperative, what brings everybody at the Alliance to work every day is the same thing that CFOs and employers are trying to do. How can we figure out ways to save employers money on their health care? So we don't answer to Wall Street, we don't answer to private equity firms, we answer to the 340 members who are going to vote today on who the board is. So when our contracting folks go out, they look for ways that are new and innovative to help make sure that contract is a little stronger than the old discount off of billed charges. We look for providers like SmartScan, Smart Infusion, who's one of our presenters today, MH Imaging, to come to the market and provide scans for employees. Every scan the 2 of those providers do, less than $1,000. The average in the Alliance, $2,800 maybe, for the same scan in the same machine. So we also think of ourselves as the voice of the self-funded employer because, like I said, that's who we're here to represent. We do a ton of work with some really good broker partners and leverage their knowledge to help us move forward and make sure we're doing the right things. So these are the things that are really at the heart of what we do. We talked about transparency earlier. How many of you have a vendor or somebody that you work with that talks about how transparent they are? We do it a lot. But I think sometimes we're transparent to a fault. So we talked about data earlier and how important it is to have if you're a self-funded employer. If you call me or you call Vicki on a Tuesday morning and say, I need to know where every penny I've spent that has flowed through the Alliance has gone so far this year, within a day you will have a report that breaks it down by provider, by TIN. Here's where all the in-network providers are, here's all the out-of-network providers. So that you can look at that and say, well, wait a minute, we've got folks going to an out-of-network provider that is in Madison. How can we fix it? You know, the other big thing with transparency is you've heard of the gag clause, the legislation that was passed that says all networks have to remove gag clauses from their contracts. In our 30 years, we've never had a gag clause. So what that means is if an employer or an employee call us and say, I need a knee replaced, I'm having it done at Sauk City, what's it going to cost me? We will give them the best cost estimate we can. If everything goes as it should, this is what it's going to cost you. There are other entities, we use that phrase, that are giving those estimates. They're using market-based averages. Not if I want to know a specific hospital, well, it's going to be about. Removing those gag clauses means that you have to give specific requests when people call. This is what it's going to cost at this hospital in your network. So the other thing that we're big fans of is payment reform. So when the first contracts were written with hospitals, it was a discount off of billed charges. So if I write a contract and I get a 50% discount at Chris's Chiropractor, that's great. I think I'm doing really good. But what we don't take into account with that is every year Chris raises his prices. So after 4 years, what's really the net effective discount that I'm getting? So what we've started to do is reference-based contracting. So I want to make that very clear. It's reference-based contracting, not reference-based pricing. How many of you are familiar with reference-based pricing? So reference-based pricing says, I'm going to go have a service done. After the hospital sends me a bill for $50,000, my insurance company is going to send them a check for $10,000 and say, this is what we're going to pay. If the hospital doesn't like it, they push back, they send the employee a balance bill and say, hey, your employer paid 10, we want the other 40 from you. With reference-based contracting, we still base our contracts on Medicare, but think of it as, again, more analogies. Reference-based pricing is walking on a tightrope across the Grand Canyon. If you probably won't fall, but if you do, it's a long, bumpy road down. What the Alliance does with reference-based contracting is the provider knows if Medicare pays me $1,000 for an MRI, and my contract with the Alliance says they're going to pay me 180%, I'm going to get $1,800 for that MRI. It's walking across that same tightrope with a net a foot underneath you. You never have to worry about falling because there's a contract in place that will save me. The other thing we are big fans of, bundled pricing. So we talked about MH Imaging and we talked about SmartScan earlier. They're bundled prices. So if you go to MH Imaging for an MRI, I can tell you right now, regardless what happens, $625. Versus going to a system, you go in, you have your scan done, you come out, a week later you get a bill that says, well, we thought it was going to be $1,800, but actually it turned out to be $2,200. Sorry. We see a lot of these with schedulable procedures, knee and hip replacements, colonoscopies, ear tubes, anything that you can schedule out, we like to try to find bundles for. And more providers are accepting them because they know exactly what they're going to get. It drives patients to them because employers will incent folks to go there, and because they're standalone, their readmission rates and their complication rates are very low. So I don't know if any of you heard, about a year and a half ago, all of the ortho docs at St. Mary's Hospital quit. They said, hey, we think we can do all these procedures for less money. Well, we don't think so. So they quit. They have opened up Orthopedic and Spine in Wisconsin down on the Beltline. They do carpal tunnel releases for, anybody know exactly? It's, say $2,500. In addition to being a bundled price that's much less expensive than going to a system, you go in and say, I think I have a carpal tunnel. Yep, you do. When can I be seen for this? Well, you got 20 minutes right now. We'll take you in the back. We'll fix it. The time that you're able to save with some of the bundled procedures, because you don't have to go into the system and see another specialist and then go get your procedure done, is becoming more and more a draw to self-funding and using bundled providers. In network plan design, I'm going to say this, and I hate to use the word never, but I'm going to use it. You will never see the Alliance sell a narrow network. One of the things that our founders wanted was to be able to get access to all the good providers. So if you tell me you need a heart transplant, I'm going to put you in a car and I'm going to drive you over to the UW, because that's what they do really, really well. If you tell me I need a knee replaced, I'm going to put you in a car and drive you out to Sauk City, because they've got a bright, shiny hospital that was built because their ortho department is spectacular. So we believe in tiering networks. So if we have a provider that's value, a bundled provider, direct primary care, we'll put them in a tier above everybody else. And then below is the rest of the Alliance network. And if you as an employer want to tier that further, you certainly can. But by tiering the network and doing that kind of network plan design, it helps your employees see where the value is for them and helps you save money, so it helps that self-funded plan work the way it's supposed to. Then we get to benefit plan design, and I touched on it a bit when I talked about tiering. We think there are ways to put a plan design together to help employees save money, help the plan save money, so that hopefully you don't have to worry about, what Todd asked, what if I have a really bad year? So this is our base network. We covered 90% of Wisconsin. Last year, employers at the Alliance bought more than $1 billion in healthcare from the providers you see highlighted on this map. Because we don't do narrow networks, you're free to choose anywhere you want. What I tell folks from La Crosse and Eau Claire, if somebody comes to Madison and they twist an ankle at a football game, walk into any provider, they're all in network. And because of the breadth of our network, we've got 140 plus hospitals and almost 40,000 providers now, you don't have to worry about going out of network. So we talked about tiering of networks. One of the things that we pioneered about 3 years ago is our Premier Network. And what we do with that is we have partners, system partners, so the UW, Gunderson, Marshfield, who have agreed to give us better discounts if we tier them above other providers in the Alliance. The uptake on that from employers has been remarkable, especially in the Madison market. We just rolled it out in La Crosse. We're getting some great uptake there. All that does is strengthen our relationship with the providers to help us continue to get better agreements to help employees save money. And again, the big thing on here, I think, incentivizing employees. If you draw a line from La Crosse over to Appleton and go north of that, the number of employers who have what we call a zero tier in their plan now is remarkable. And what the zero tier is, it tells employees, if you go to these providers, you don't pay a dime. Because we as the employer know, after working with our quarterback and our network partners, exactly where those value providers are at. And that's the one thing that the Alliance does on a regular basis that most networks don't do. We help you figure out who goes in that zero tier. So if we bring on a new provider in June, we're going to call and say, hey, you may want to think about adding them in because they're doing these procedures for this cost. Once employees understand that that doesn't cost them a thing, the uptake on it is remarkable. We at the Alliance now have that exact plan. So this year, my wife and I have seen our DPC provider probably 24 times. We have paid zero out of pocket. And she's going to see a podiatrist, she's going to see, all kinds of doctors. She's had a bad year. And again, data is the key. So we can look at how many MRIs did your employees have last year? How many were at a system? What did that cost? If all those folks had went to SmartScan or MH Imaging or MDI in Milwaukee, here's what you could have saved. Now, we're not naive enough to think you're ever going to get 100% of the people to go, but if you can increase that incrementally, you continue to see more savings in your health plan. So, you'll see spots on the map that are not highlighted. Folks say, well, what if I've got employees there? We have partnerships with WPS Auxient to take our network and wrap that with the statewide network. So you have access to every single provider in the state of Wisconsin. Almost. I said every. 99.8%. We also have a partnership with an organization called Trilogy Health Solutions out of Milwaukee. Great partners. We've known them for years. They bring us access to all the major players on the east side of the state, the Auroras, the Freighters, the Theta Cares, and to Mayo on the west side of the state. So we have solutions to get access to every employer, every provider in Wisconsin. And I'd say if you go as far south as Elgin, Illinois, and north, we're an extremely viable option down there as well. Illinois is a different animal when it comes to contracts and the savings rates, but if you have anybody in Rockford or McChesney, we have a provider network there to service them as well. So I've got about 1 minute left, Jess, ish. So I want to talk about the top bullet point here, smart savings. So our analytics team will look at the claims data that an employer sends us and figure out, based on how far they want to steer their employees, whether it's 30 miles, whether it's 50 miles, whether it's 100 miles, and we will give the employer the information on where their employees could go to find value, how much they can save, and what we think the incentive should be. Because I've seen a couple of occasions where the employer will say, hey, if you go to where I'd asked you to go for a knee replacement, I'll give you $100. And the employee says, well, wait a minute. The place I want to go, it's 60 grand. The place you want me to go, it's $35,000. You're going to save $25,000 and give me $100? Weh. Plus, human nature is I'm going to do what's least disruptive for me. So if my employer wants me to drive 70 miles to have a knee replaced and I'm going to save $30,000, I'll either make it free for you or I'll give you $2,500. Because we have employers who have tried to do steerage with, we're going to decrease deductibles and decrease co-insurances. Employees, after they leave their open enrollment meeting, life happens and they forget it. Here's what they understand. I'll give you $2,500 cash, or it's free to you. I understand free. I know what $2,500 looks like. We've seen incredible adaptation of the steerage programs that we show folks when they do those kind of things. And again, for us as a network, we have benefit partners that I think are outstanding, and they help carry that message to their employers. All right, so thank you very much for coming. Enjoy the rest of the day. We have a great speaker this afternoon that I think you're really going to enjoy. If you have any questions afterwards, my information's on the website, phone number, email address, give me a call. I would love to talk to you about anything we talked about today and more in depth, or if you have a client that may be interested, I'd love to talk to you about that as well. Thank you very much.